Sriram of NIST and Egan Rinderer of Ninja One. Gentlemen, welcome. Thanks for joining me today. Ram, I start with you. How have EHRs evolved over time to get where we are today, and how do you expect to see them continue to evolve over time?
And thank you very much, Francis, for giving the opportunity here. EHRs actually evolved through several cycles. Initially, when they started, people were really using it for payment processing and scheduling and those kinds of things. And now they have evolved to be more reactive. And what has happened also in terms of their programming also, initially they were all put together bits and pieces. And later on, people have used some more modular techniques to build robust EHRs. Now, what's happening in EHRs nowadays is that with the advent of artificial intelligence, the EHR vendors are trying to incorporate these technologies into this. So what's happening with EHR is that the EHR is not just a repository for the doctor to put history and physical and all the data that the doctor collects in the office or the hospital collects, but rather it's going to be an active system rather than a passive system in the future. And there's other thing that is going to happen in the future. Like, for example, I wear a Apple Watch, and this is constantly monitoring me. Similarly, all these devices are going to monitor us all throughout the day. With the food we eat, your walking, that's being monitored, your physiological state is being monitored, everything. And all of them are going to go into something called you can call it an health persona of individuals. Now, that's one part of it. Then you have the electronic health records, which are going to incorporate all the lab data, imaging data. In addition to that, your genomic data also. Because what happens is that there are certain patients, they have some gene variations, and you cannot give them, for example, warfarin if they come with a stroke, okay, because they have a certain variation. And that information, if it's there in the EHR, you don't need to, you know what happens on that thing. So then you attach this EHR to your health persona, you get what is known as a personal health record. So in the future, that will be the main thing, the personal health record. And also, we will evolve from a doctor-centric or hospital-centric view to a patient-centric view. So the EHRs and the PHRs will evolve into a patient-centric view. And not only that, they will be active and intelligent. That's a very brief description, but we can go into details.
And I want to do that because you have a lot of experience in some of the areas where these technologies are breaking now. Egan, welcome. Thanks for joining us today. What do you see? You also have a lot of experience in this area from a lot of different perspectives. What do you see as the most important developments that people on the federal side should be paying attention to as these things develop?
Yeah, I will say I don't think there's a tremendous discrepancy between the federal and the private sector when it comes to patient care. I tend to be very hard on vendors, and I am a vendor. I take that. I'm very passionate about scrutinizing my work and the work that we do as a company. But I go all the way back to the early 90s. The first startup I was involved in was an electronic payments disbursement. We helped physicians bill electronically, and that was novel at the time. And I left that and founded a company in the late 90s. We're talking 7-8 years before the first iPhone came out, that provided EHR access to physicians via tablets over, at the time, cellular data packet radio modem. So like the things that they used in utility vehicles, right? This was, at a time when Windows 3.1 was, Windows 98, Windows ME had just come out. Like this was very, very arcane technology back at the time. But what was interesting about it is that it provided, the draw that physicians had toward it was that it was a catalyst, right? It helped them provide better care to the patient without getting in the way. And then as time progressed and there was more, HIPAA became a thing and people sort of started smelling the opportunity to cash in on bringing IT to bear in healthcare, things changed dramatically. And it became more about how hospitals could collect the data they wanted, as opposed to how can we provide better patient care. And what's also interesting at the time is my sister was graduating from med school, going into practice, private practice, and I watched this evolution through a physician's eyes. And I saw the frustration because what was happening is she was spending more time with the IT systems that she was given to purportedly improve patient care than she was with the patient, right? And we saw that trend continue, and now the industry has sort of shifted back to this idea that, oh, we need to become more patient-centric. And I think that technology has reached a point. There was this interesting aligning of the stars in the late 90s that allowed some really novel things to be done around automation of patient care and improving patient care through technology. We're sort of at one of those inflection points again now, where the pragmatic use of AI, right? Not the blanket use, not throwing a sticker on a thing and saying we're going to leverage AI now, but the actual pragmatic use of AI, like Tim alluded to, right? Note-taking is a huge burden. In fact, my oncologist, who's a phenomenal doctor, has a person whose job it is to take the notes while he sees me so that he isn't distracted by banging on a keyboard. It shouldn't have to be that way, right? Technology has reached the point where it doesn't have to be that way.
Yeah, and carrying that, actually, you made a very important point. Tim also talked about this automated note-taking thing. So I think one of the things that's going to the future office of the doctor will be, you have these videos, audio, everything. So you're just talking, you and I are talking, the doctor and the patient are talking. And there's also other kinds of irrelevant questions that are being asked and things like that, like how is your family and so on. You don't want that to go into EHRs. And these things will be smart enough to take out all those things and only put the appropriate information that is required in the EHRs. And hospitals are doing, and there are offices which are experimenting with that right now, and they're using that. And that's pretty neat because the doctor doesn't need to go and type on the system all the time. Instead of that, your main goal is to do a patient-doctor interaction, and everything is automatically done. And another thing that is going to happen is that a lot of times when the patient goes to the doctor, there are certain emotions which has to be captured. Like you'll say, oh, I have a stomach ache, but you really don't have a stomach ache. But if you can capture that facial recognition kind of things, and the system captures the emotions and tells the doctor actually at the automated system that, really the person is not really sick, but is feigning to be sick kind of things. So these are the kinds of things that you're going to see in the future. Of course, previous speakers have talked about privacy and so on, and that's going to be an important aspect of how do you manage privacy, security, and those aspects of it. And there's something, we came up with something called P9 medicine, where medicine is participatory, preventive, predictive, and so on. And there were 9 Ps involved in there, and privacy and protectiveness. And also it has to be appropriately priced. That's very important because medicine, as you know, is very expensive. And the idea is to reach the medicine for all at a reasonable price.
What do we need to do as a country, or what does the federal government need to do to get from where we are today to the vision that you just described?
There are lots of agencies in federal government who have specific tasks of doing these things, but my agency, NIST, is more in terms of helping this whole process. Like we are actually in the Constitution, if you know that Article 1, Section 8 talks about weights and measures. Okay, so we really are in the process of making sure that these systems work perfectly. So in terms of trustworthiness of the systems, benchmarking, and I guess Molly talked about the certification process, and we develop a lot of tools to help in the certification process. So we develop the testing tools. So right now we have been testing tools to develop the standards that have already been developed by, are supported by ONC and so on. But in the future, we also have to have these tools which are actually use AI techniques to automatically generate the interoperability between various systems. So we are mostly in the R&D kind of area, but in terms of the incentives the federal government provides, and there are other organizations like ARPA-H or HHS and those organizations which are putting in actually considerable amount of funding to make this happen.
Ram talked about testing and the importance of that. What does that look like from the vendor perspective, and what does that look like from the provider perspective, who maybe doesn't want to be involved in being a guinea pig in the
and I don't think there's any maybe about it. I think the vast majority of providers are looking for ways to be able to hit the patient numbers that they're loaded down with and provide good care. That's what they care about. From their perspective, the patient isn't data, it's human, and that's the way it should be. From the vendor's perspective, I think the number one thing that I see that's sort of this battle of wills between whether it's NIST or the federal government writ large and the vendors is the vendors are very protective of their intellectual property. And when it comes to AI, your intellectual property protection means I don't like transparency. When it comes to healthcare and AI, you need absolute full transparency. There is no other way to do it responsibly. And I'm very happy that I'm not on the regulatory side of that fight. As a vendor, we have a very open approach to that. Our AI that we use inside of our product is extremely pragmatic, extremely simple to understand how it's being used. There are no privacy issues with the way that we're using it today. But I think we have to come to terms between the will to make a dollar and the will to protect people's privacy, security, and health. And if that's not understood which side of that argument should win outright, then there's probably a different discussion.
That's right.
Yeah.
What does that conversation continue to look like as technology evolves in some of the ways that Ram described and you talked about earlier? Strikes me, and privacy and cybersecurity have been themes of this conversation on this entire program so far, and I imagine they're two of the things that you think about all the time.
They are, and here's the struggle, is the people who have the most vested interest in protecting that are the least equipped to discuss it, and that's a problem. That's why we have regulatory organizations within the federal government. That's why we have chosen as a people of a democratic society to establish organizations like that. When experts talk, we need to pay attention. But that goes both ways. It cuts both ways. So when the technology experts talk and they say, look, here's how you properly secure this, here's how you employ proper transparency and traceability of the data and all of the things, we need to be listening to the patient care professionals as well and say, that's all great, but this comes first. The patient's well-being comes first above and beyond all of that. So sometimes those two things can be in conflict with one another in terms of the speed at which we can move and progress technology into medicine. I think that natural friction is okay, and it should probably be maintained over time. So it does slow things down a little bit, but that's an acceptable rate of progress, I think.
And Egan also mentioned, continuing on that, about AI incorporated in their system, but we also need to have certain tools and techniques to measure this thing.
Yeah.
So metrics are very important. Like when people are talking about large language models, you get output from them. So how do you measure the trustworthiness? How do you measure whether this is right? What are the metrics in there? And these are some of the things that we are interested in.
You frame that as kind of a rhetorical question, so I'll ask it as an actual question. How does one measure trust in something? How does one measure the outcomes, the outputs that you're getting for accuracy and so on?
Yeah, that's a pretty good question. Take a long time to answer that in any case. But there, even in trust, there are several aspects of it. So you got to, first of all, clearly identify what are the various aspects of it. And then you need to show that how we are going to measure this particular thing. So trust is only one part of it as such. And the other is reliability of the systems, uncertainty, quantification of the systems are very, very important. So the number of dimensions of these things that you have to look into. And, it's a research area that we are pursuing, and so something of interest to us.
It's really, we could do a whole show on artificial intelligence in this space. This is an issue, though, that you've been involved with, I read, for 30 years or longer. I think a lot of folks think artificial intelligence is relatively new.
Actually, I started working in AI about 1982. So it's been almost 4 decades. And I've seen several waves of this AI. And in the 80s, it was mostly knowledge-based systems or symbolics. Then in the 2000s, you have seen the evolution of neural networks, and they call it deep learning. And then deep learning has itself certain flaws because they're very good at pattern recognition, but sometimes they tend to they don't know the reasoning. So, and then people are now combining these knowledge-based systems of the 1980s along with the neural networks, and we are seeing the evolution of neurosymbolic computing. And this neurosymbolic computing is going to play a major role in the future of AI in medicine.
What will drive that, and what will the result be in your view?
What will drive it is because what has happened is that in terms of the deep learning, as you have seen some arguments even by Turing Award winners and the Nobel Prize winners on this, is that these systems have come to a stage where they come to a deep end kind of thing. Okay, so and they're also like, for example, the LLMs. There's something called hallucination, but also it's a different word people use for that. They can make up some things. So if something makes up something, then these knowledge systems will have to come back and say, no, it's made up. If it's a context. Mm-hmm. Now, in other words, if a child goes to the hospital and they say you got lung cancer or something like that, and the knowledge system will come and say, no, this particular kid could not potentially have that thing, and there are other things that we need to look into. So it's a combination of this neural network, which is doing this, which is what is a system one kind of thing, which is doing this processing, and there's another system, which is a slow system, which is system 2, which has to make sure that is actually working properly. So you have to have both the system 1 and system 2 to make it a robust system of the future.
There is so much more I would like to cover with both of you, but we're out of time. Ram, Egan, thank you very much for joining me. It's great to have you here.